Thank you. All right, so I'd like to call this work session to order on mental health first responders. Let's start with the roll call, please.
Yes, Mr. Chair. Ms. Allard?
Here.
Mr. Constant? Mr. Dunbar?
Here.
Ms. Kennedy? Ms. LaFrance?
Here.
Mr. Perez-Verdia? Mr. Peterson?
Present.
Mr. Rivera?
Present.
Mr. Weddleton?
Here.
Ms. Zolotel?
Here.
Thank you.
Thank you. As usual, for members that want to get in the queue, please put yourself in the chat or text me if you can't access the chat. All right, so with that, I'll go ahead and turn it over to Ms. Colston, and I believe Mr. Lassard are going to be doing our presentation today. You're on mute if you're trying to speak, Ms. Colston.
Good morning. Jason, do you want to start or do you want me to start?
Why don't you start, Steph? Thanks.
Okay. Well, good morning, everyone. My name is Stephanie Colston, and I've been asked today to talk about a deep dive into the core program of the Anchorage Fire Department. And before I start, I would like to thank very much Lieutenant Gina Burrington and Melina Breland from the Anchorage Police Department, and Chief Hetrick, Michael Riley, and Deputy Chief Schuneman for all of their help with numbers, with approaches, with innovations, and thoughts in general. So very appreciative, and hope this reflects everything we discussed. If I'm not sure if my slide, I'll just go ahead. And does everyone have a hard copy, or how?
I believe we were emailed the slides, but if you could put them up on the screen, that would be great.
Okay, let's see here. Get the. PowerPoint. Okay. Is it up?
I am not seeing it, no.
Oh, shoot.
Jennifer, do you have the presentation, and could you put it up?
Can you see that, Mr. Chair? This is Meg, but.
Yeah, we can see that.
Okay, I'm happy to advance it for you, Ms. Colston.
Sorry, Assemblymember Zolotel, thank you. Okay, slide 2 is really what a mobile crisis team component might look like. This is the kind of standard, I guess I would say, with 3 purposes: de-escalate the crisis, stabilize the individual, and refer, connect to services. And through that, and I would say that these are based on the mobile outreach and crisis response service component of Alaska's 1115 Medicaid waiver. So the services to be provided with that service include triage and assessment, the actual intervention, crisis intervention, hopefully stabilization, referral and linkage to a provider if treatment is necessary, mediation, and skills training. The service is required to be available 24 hours a day, 7 days a week, with a 1-hour response time in urban areas. The minimum staff required are a mental health professional clinician as defined in Alaska Administrative Code, and other qualified behavioral health professional. That is an and not an or. And that could be several different categories: a behavioral health aide, a behavioral health clinical associate, a peer support specialist, or a community health aide. And the requirements for each of those vary, but generally it is bachelor's degree or higher. The other requirement is a 48-hour follow-up. The purpose of that is to coordinate with law enforcement and whatever crisis service, if any, you can refer the individual to, if that is 23-hour crisis observation and stabilization, or whether that is crisis residential, kind of a crisis stabilization unit where they stay anywhere from 3 to 6 days. The other requirement is that SAMHSA's 10 crisis expectations are met, and SAMHSA's 10 crisis explanations are very broad. Avoid harm, intervene in person-centered ways, share responsibility, address trauma, establish feelings of personal safety, try a strengths-based approach, the whole person, look at the person holistically, physical, mental, any issues. Treat the person as a credible source, and have a focus on resiliency and recovery, and a prevention focus to prevent the crisis from occurring in the future. So very broad expectations that SAMHSA has. Slide 3 is thinking about CORE and how to transform CORE to a mobile crisis team concept based on those requirements. CORE, as everyone knows, is Community Outreach, Referral, and Education. It was established by the fire department in 2018. It has a wellness and health improvement focus, but it is focused on high utilizers of their emergency medical services. The staffing is a paramedic and a behavioral health specialist, which is a master's level clinician. The services are identify and monitor individuals in crisis. In other words, they could be in crisis, they could be beginning to escalate into crisis, divert them to services, provide a brief intervention as appropriate and necessary, and provide initial treatment for life-threatening injury or illness until they get to the ED. So it's a pretty broad scope right now, but it will be much broader as a mobile crisis team. One of the important things about CORE is that it has the infrastructure in place to kind of transform to a mobile crisis team, if you will. Safety, communication systems, human resources, and operating systems. Last but not least, CORE coordinates very well, I think, with existing municipality and community resources. So what's next to transform CORE if you decide to do so? I think CORE has a specific identity, and in order to transform it to the mobile crisis team, it would be helpful to change the name. I think, remaining in AFD is certainly a viable option, and one that I'm recommending. But to do that, somehow that mobile crisis team has to become a Medicaid eligible provider, or some component of AFD must do so. Now, there are several ways to do that, which I'll talk about in a while. Services would be assessment, crisis intervention, referral linkage, suicide prevention, conflict resolution, and trying to provide some skills training if there's time to prevent crises from happening in the future. The staff would be based on the mobile outreach and crisis response staff qualifications, which I talked about earlier. The one master's level clinician and one behavioral health aide. You can have a peer support specialist. So that's important because peer support specialists have been very successful with mobile crisis teams in the past and in other jurisdictions. So there are a couple of options in terms of the paramedic. Just need to kind of think through what role the paramedic will play, because it will be a different role than on the core team. Basically, the core team should have a clinical lead, and the master's level clinician should be hired with the expectation that they will be able to provide the clinical supervision for the effort. One thing that I have spoken with AFD about is requesting a regulations consideration by the state Division of Behavioral Health of DHHS, and for what they call a village public safety officer designation, which of course is used in the rural areas of Alaska pretty successfully. Okay, thank you. Next slide. AFD has been very responsive and helpful in thinking through staffing for a mobile crisis team model. And this slide can be kind of confusing, but basically the type and number of staff have more to do with whether they can provide 24/7 coverage. For year one, AFD has suggested that at this point, though I have to say they're very flexible, that 8 staff be staffed for the unit. That would be one team, and they would provide what I call 12/7 coverage and during the peak hours.
8 staff, one team?
Yes, ma'am. I'm sorry.
Go ahead. I think that was accidental. So if we can go
Oh.
ahead and continue. And if you're not
Yes, I
speaking,
did
please
say
make sure
one
you're on
team.
mute.
Sorry.
Thanks.
Then year two, there are 2 different, year 1 and 2. There are 2 different options for year 2. Remain the same with a slight cost of living increase. So in other words, 8 staff. Or go ahead and expand during year 2 to 24/7. That would basically be double. 4 paramedics instead of 2, 4 master's level clinicians instead of 2, still 2 case managers, 1 admin support, and 1 operations manager. So you would have 4 teams at 24/7 staffing, whenever it is, whether the assembly wants to have 24/7 year 1 or year 2. The issue with 24/7 goes back to slide 2, where we were talking about the components. And in order to receive Medicaid reimbursement to defray some of these costs, it has to be 24/7 coverage. Next slide. The money that is attached to those staff are broken out into 3 different years. But again, year 2 has 2 different options. So for year 1, it's the labor costs are $1,000,004. Add $131,000 of non-personnel costs, computers, supplies, SUV, and you have 1.6 million, 1,575,180. Year 2, this is the option 1, which is the same staffing as year 1, is a little bit less, 1,000,003. The costs, of course, non-personnel costs, they're not going to have to rebuy everything. So 72,281 for a total of almost 1.47 million. Then for 24/7 coverage, whether it occurs in year 2 or year 1 or year 3, it doesn't matter. The labor costs will be 2.3 million, non-labor 72.2, and then total of just under 2.4 million. Okay, how to finance it. Done a good bit of research here, and it appears that the 1115 waiver could cover maybe 25%. I estimated 25% of your total costs. It could help defray those costs. And then the alcohol tax, which I believe, as I mentioned in the next couple of bullets, has already been discussed by the Assembly. Again, in the third bullet, I want to reiterate, just need to get past how to qualify as a Medicaid behavioral health service provider. Now, AFD already receives Medicaid for transportation, but this is a totally different set of requirements to be a behavioral health services provider. Then, of course, which service to bill, the mobile outreach and crisis response. I list the payment rate there because it's important for future slides. It's $175.64 for each call out. So now we get to some of the estimates of Medicaid revenue and some of the numbers challenges for those estimates. We made the assumption based on lots of discussions with lots of individuals that 60% of the total mental health related crisis calls will be diverted to the crisis response team. Assumption 2 is where it gets kind of tricky. We made the assumption that approximately 12,200, as you see there, 10,000 APD and 2,200 fire department, will be the total number of calls per year. If you take 60% of that number, then that means 7,320 potential calls that could be diverted to the mobile crisis response team. Subtract that out and you get 4,880 takeout calls for the response team per year. Now the 10,000 number is truly an estimated projection. It is based on 1 month of call data from APD. And here's the explanation. APD has in the past used 2 categories for mental health related 911 calls: a suicide attempt or threat and what they call a mental person. Clearly, there are other types of calls that can and do involve persons with mental health issues. So I recently requested some data from APD, and they used the October of 2020 call data. That's 1 month. And for October 2020, it happened to be 551 calls. And those are calls, again, for suicide attempt or threat and mental person, those 2 categories. And they tracked different call types that came in with a mental health nexus. They saw 1.5 times the number of calls. In other words, 827 calls, not 551. So the 10,000 figure comes from making the assumption that what APD saw in October remains true for the year. So, for example, for 2019, 1.5 times the projected total is just under 10,000. So that is the number that we used. And a huge reason for that is both the experience of APD and AFD indicated that they thought that was a pretty reasonable number. The AFD calls of 2,200 are based on 5 years of call-out data for behavioral and psychiatric disorders and a portion of the substance abuse related callouts. We counted, of course, 100% of the behavioral psych category, and we assumed that 3/4 of the substance abuse related categories involved co-occurring mental health issues. So I think these are probably the first time these numbers have come forward. Again, they're far from perfect, but they align with local experience, and that's probably the best explanation and the most reasonable explanation that can be given for that. I think it's important that whatever local data you have be used. The fourth assumption is that each Medicaid reimbursable takeout call will be billed for Medicaid at the waiver MCOS rate of $175.64 per takeout call. And remember, of the total calls, we're assuming that 70% are Medicaid reimbursable, which relates to the next slide. So this is potential Medicaid revenue just for the first 3 years. And it'll change, of course, if 24/7 is implemented earlier. For year one, there would be no Medicaid revenue. And AFD's projected cost is that 1.6 figure, I'm rounding up. So the potential additional amount that would be needed would be 1.6 million. For year two, I'm assuming that 3/4 of the 100% of Medicaid reimbursement would, in other words, 75% of the total would be eligible for Medicaid reimbursement. That ends up being $449,990. That, again, the projected annual cost at 24/7 bumps up to that 2.4 figure. So you would need 1.9 million to cover the difference. For year three, 100% of the eligible Medicaid reimbursement, that's almost $600,000, just under. And again, at the 2.4 figure, that leaves about 1.8 that would need to be covered. I think there are lots of items to consider, but two of the more important ones are the first bullet. How quickly can MCT begin to collect Medicaid revenue for behavioral health services? And again, I probably don't need to say it, but must have 24/7 coverage to be able to do that. And secondly, I have spoken with a couple of providers, behavioral health providers in the community, and they're in the beginning stages of developing a proposal for crisis observation and stabilization 23-hour services, which is an important service to have in the community when you implement mobile crisis teams. Crisis residential stabilization, which is an inpatient type unit. It is considered residential instead of inpatient, but it is literally a crisis stabilization unit, average length of stay anywhere from 3 to 6 days. And they are considering a mobile crisis component, apparently. In terms of Assembly policy guidance, I think this is a great opportunity that the mobile crisis team offers to coordinate existing municipality and resources and to continue working with community providers on future directions. And I think, there are policy issues that need to be communicated, policy direction. The second bullet is the importance of coordinating with existing resources and thinking through provider's role. One of the things that I had thought of was, if it is a long period of time before somehow AFD can become a behavioral health services provider that is eligible for Medicaid reimbursement, perhaps contracting with a provider would be reasonable. I don't know. It is an option. I just am mentioning it, but I somehow think that that issue is going to be resolved pretty quickly. I do want to stress the importance of training and technical assistance. I think that needs to be pretty structured and very clear. I think there's training involved, and I thank Assembly Member Constant for this. There's training involved for the actual MCT team, and that's very structured. They need to be trained in mental health first aid. They need to be trained in crisis triage. They need to be trained in de-escalation techniques, just a whole series. There are several curricula out there that relate to training crisis teams. Also, there's a less intense level of technical assistance for other entities that are coordinating and working with the mobile crisis team. And that is not as strict a training regimen, of course, as you would have for the mobile crisis team members, but that technical assistance does need to involve understanding and going out with the mobile crisis team and understanding what they do. Last but certainly not least, a public education campaign to maybe for mental health first aid, which is a kind of a public-oriented mental health training. It's not a very rigid training, but it is very helpful training for understanding and assisting with mental health crises. Operational factors, there are all kinds of regulations involved in providing Medicaid reimbursable behavioral health services. There are separate waiver requirements and regulations. And I think in order to be efficient and effective, those are critical components. And then, of course, sustainable startup and funding sources. I mean, a combination of the alcohol tax and waiver reimbursement, you don't see that every day. And therein lies what I think is a good opportunity to move forward. I think the feasibility of CORE as a foundation for mobile crisis team starts with leadership at the fire department, and that leadership, in my opinion, has been very responsive, very positive, and aligned with this model. Very flexible. I believe it is the most feasible option within the timeframes that exist. I believe that it can easily meet the minimum requirements outlined in the SAMHSA national guidelines, and it will require a totally new approach. This is not CORE as you know it, but the infrastructure is in place at the fire department to do this. Also, and I keep mentioning this, I'll try not to mention it again, it will require becoming a Medicaid eligible provider or partnering, figuring out a way to address that issue. The funding sources are there, we've identified them. And last but not least, the fire department has a long history of collaboration and coordinating with municipality and community resources. Any questions?
Thank you. Mr. Weddleton.
Oh, thanks. Yeah, I've got a couple questions, and some are just definitions. So what is a takeout call?
It's actually the call where they respond to the crisis, where they actually go out.
Oh, so on some they wouldn't physically go out. They just talk to them on the phone then?
Yeah.
Okay. What is, you use the phrase waiver MOCR staff qualification. What can you embellish on that?
that's what exists in regulation for the mobile outreach and crisis response services that are listed under the waiver. If you look at the regulation, there's a whole series, and I'm happy to give it to you, of definition of the service, what types of providers are qualified, what the legal authority is, and for example, they set the requirement that it has to be 24/7, response time in 1 hour. All of that is laid out in that regulation. So they have minimum qualifications that must be there.
Okay. Can I follow up?
Sure.
Yeah, go ahead.
So why would we need a waiver? What features would we not be able to comply with? And
well, the waiver exists. What I'm suggesting that you do is use that existing resource to help defray the costs of the program.
Well, but I mean, a waiver. I understand. Okay, we can't quite meet the standard requirements, so we get a waiver, so we can qualify without doing certain things. Is that what's implied there?
No. The state of Alaska received approval for a waiver to their state Medicaid plan in 2018, and that has been in existence now for 2 years. Under that waiver, they developed a whole series of services that did not exist and do not exist under your state plan. It is an evaluation and demonstration waiver where the state of Alaska said, we're going to do some new and different things in order to keep people out of psychiatric hospitals like API and emergency departments. And this mobile outreach and crisis response service is one of those.
Okay, good. That helps a lot.
I'm sorry.
One last one is, we AFD gets Medicaid for ambulance transports, but it's apparently not reliable. In fact, we changed our budget because we didn't get paid what we thought we were going to get paid. So would this be more reliable than that?
Well, it should be, but it is such a different type of service and the requirements are entirely different. But once all of the systems are set, that's the beauty of at least being familiar with Medicaid reimbursement in the fire department. While it will be different and much more challenging, I think, as a behavioral health service, at least they understand what to do, how to bill, and that kind of thing. So it should be more reliable, but I would hesitate to give an opinion on whether it will be.
Okay. All right. Thank you.
Yes.
Thank you. Are there any other questions? And I believe we have a second presentation by Mr. Lessard. Is that true? Okay, great. So any other questions for Ms. Colston? All right, not seeing any. Thank you for that presentation. Very much appreciated.
Thank you.
Turn it over to Mr. Lessard now.
Thank you, Mr. Chair. I actually don't have a presentation. I've been a part of the conversations with Ms. Colston, Zaltel, in the smaller work groups, and believe I was invited due to that. So I don't have anything specific to present, but I just wanted to thank the Assembly for taking the time and putting the effort into this work. It's really important. We've seen time and again in other communities that a change in our response to these behavioral health situations will present a change in outcome, a positive change in outcome. And so, I just wanted to re-stress the importance of that and what we're seeing elsewhere. And also wanted to just point out that, I think going through the process of doing the work, particularly the work that Ms. Colston's been doing on this, shows that we haven't been taking good measurements. And something that was always drilled into my head in operations background was that, you can't properly manage something that you're not measuring. And so I'm hoping that coming out of this will be a more of an effort from all individuals involved to really track what we're doing so that we can manage it to the best of our abilities and the best of our resources. And I'll just end it with that. I'm happy to be here to answer any questions. And thanks again for the work and for allowing me to be part of this.
Great. Thank you, Mr. Lessard. Chief Hetrick, would you like to add anything?
One, I definitely just an appreciation of allowing us to continue working through the process. We had lots of conversations with Steph, and it was great. Helped us kind of refine our proposal and what we were talking about doing, and then looking at that 24/7 operation and how we could get there was something that we had kind of put on the back. Thinking that the very first year we would start with 12-hour staffing 7 days a week, just because we had never really done this before, and kind of work out the kinks. But we would definitely support either way that we go. And just again, thank you for continuing to listen to us, and hope that we could solve an issue.
Thank you, Chief. All right, so I'll go back to the queue, see if anyone else has any comments or questions. All right, I'm not seeing any at the moment. Well, again, I want to appreciate and give thanks to Ms. Colston, Mr. Lessard, and Chief Hetrick. I very much appreciate your work on this, as well as I know Ms. Zalatel's been helping out a lot. Okay, go ahead, Mr. Weddleton.
Oh, thanks. Since everyone was mute, you know, I every time we deal with this, I say there can't be a more expensive way to do this than through the fire department. But you know, I think as we flesh this out today and over time, I think I have a better understanding of it. I still think it's an expensive way to go, but I do see that there's other options. And one of the concerns is, you know, 3 or 4 years down the road, this is a big dollar amount thing, and if it comes a battle between a ladder truck or financing an ambulance or something like that, this program gets cut. And it's just, things are vulnerable, and you know, we've seen that in the fire department. But I think that this has flexibility to move to a different department. There may be different funding sources and so on. Gaining some comfort on this. And I guess since we have just a little time, I wonder if Jody, you could tell us, I mean, what are by doing this, are you saving resources elsewhere in the department, or is it just we're providing services that we obviously need, so we're ramping up the level of service?
Assemblymember Whittleton, through the chair. It's a little bit of both. One of the things we struggle with here at AFD is most of our employees who get in this line of work truly do care about the community. And it is devastating to us when we go on the same people time and time again, and we cannot solve their problem. If it's a medical situation, we get them to an ER, and you know, at least their situation gets addressed. But until we established the core team and then started going down the response, it's just this never-ending waterfall of seeing the exact same people over and over again, and it causes some, basically, is stress and trauma for our people, because they have no resolution, and they see these same people struggling with the exact same thing over and over again. It also, because of that, we have an increased call volume. So we spend time with people who we would like to see them resolved and never see them again because their situation was handled. Instead, we see these repeat customers that if we could resolve that, it would reduce our call volume. And we expect our call volume to increase. The aging community, you know, a variety of reasons why our call volume increases. So this would be a good to, you know, kind of push off that continued increase of call volume by addressing a population within the community that will no longer become repeat customers because we've helped them with something. The other side of it is the community has a strong need for this type of service. I have personal experience with it with family members. Many of the people in the department do. We really need to do something, and AFD wants to be involved in that, mostly because it really ties into what we do, and that is serving the community before, after, and during an emergency. So if we can be on that cutting edge, it isn't any different than our community risk reduction program. If we can reduce risk to our community, then it builds a safer community, which is a better place to live. It helps us attract more applicants. There's a long list of benefits to why we want to be involved in this situation.
All right, thank you.
Thank you. Deputy Chief McCoy, did you want to comment on this particular point?
I do. Thank you very much, and good afternoon, everyone. So as Chief Hetrick mentioned, there's a strong need for these services in the community. And here at APD, we strongly support this model and us moving forward with this program. And yes, to Mr. Weddleton's point, this is an expensive solution. However, as we saw the numbers, with us putting the appropriate resources to AFD to address this, we're going to free up those a large majority of those police responses to these incidents in our community, which bears a financial burden, as well as, quite frankly, the police are often not best suited to handle these situations. And across the country, we've seen bad outcomes from a law enforcement response to mental health. So granted, yes, this is an expensive resource. However, I think it's money well spent that will serve our community to the best of our abilities, and it will also free up law enforcement to investigate crime where we're much better suited. So thank you. And I appreciate everyone's continued work on this, and I'm very pleased to see the progress that's been made.
Great, thank you. Ms. Zolotel?
Thank you, Mr. Chair. I want to take an opportunity to thank Ms. Colston, Mr. Lessard, Chief Hetrick, and their teams. They've really been working hard on this and drilling down into the details. We do have a little bit of time with Ms. Colston left on our contract. I just wanted to flag that for everyone. She still is going to look at provider capacity to do this particular kind of work as well in the private sector. It's been a concern that there isn't necessarily that capacity, or likely it may have happened, but we did want to have that evaluation point. And I know that's coming before the end of the year, but we did want to explore this piece now in light of the alcohol tax proposal and that decision point coming up soon. So I just wanted to add that a little bit more fulsome picture there. And again, invite members if there are questions that we need to get to Ms. Colston on that remaining piece or something else. I'm happy to facilitate that. Thanks a lot.
Great, thank you. All right, not seeing anyone else in the queue, I'll go ahead and close this work session, and we'll see everyone again at 1 p.m.